Hey, what's up, guys? It's Ken Omertag. I'm a physician here at the Washington University School of Medicine in the Department of OBGYN in the Division of Reproductive Endocrinology and Infertility. I am the second year medical school course master for OBGYN, and this is a digital version that I'm doing for the lecture that I've given in the past about infertility. We're going to cover the infertility workup in this talk. We will cover all the elements of the workup, and then we will spend some time. We'll have another video talking about treatment. I hope you enjoy it. Let's go on. So first of all, in order to understand infertility, you have to kind of understand what the baseline efficiency of human reproduction is. And at baseline, humans are not very efficient at reproduction. And this is kind of, despite what we're told in junior high, right? Because in junior high, we're told that if you have unprotected intercourse one time, there's a 100% chance that you're going to get pregnant. That's not actually biologically true, because there are a lot of events that have to happen in order for that for live birth to happen out of one unprotected intercourse event. But it's an important point that we state to kids growing up so that we can try to avoid unintended pregnancy, or it's one element of trying to avoid unintended pregnancy. The unintended consequence of that message, though, is that people have a kind of distorted reality as to how efficient human reproduction actually is. The reality is the maximum fecundity rate, or the likelihood of getting pregnant per month, is at best 20 to 25%. It's not 100%. So if someone who has no problems, who's 25 years old, a couple having unprotected intercourse, their likelihood of having a baby in a given month is, having an ongoing pregnancy in a given cycle is 20 to 25%, even if they're having frequent unprotected intercourse. So that sets up, it is cumulative, however, and that kind of sets up the next point, which is if you keep having unprotected intercourse over a period of time, you are going to increase the chances that you will conceive, because reproduction is a cumulative event game. If you keep having unprotected intercourse over a period of time, you will conceive eventually. And here, this kind of outlines what that efficiency looks like. So after 3 months of unprotected intercourse, 50% of couples will conceive. After 6 months of unprotected intercourse, 75% of couples will conceive. After 12 months of unprotected intercourse, 85% of couples will have conceived, and then at 24 months, 93% of couples should have conceived. Obviously, as the age of the woman increases, this efficiency decreases, okay? But you'll see that I've boxed these two areas, and that's because those are the 6 months and 12 months are the criteria that we use when we define infertility. So unprotected intercourse for 12 months in someone under the age of 35 is infertility and grounds for initiating an infertility workup. Because at that point, 85% of couples should have conceived. So if you haven't, it makes sense to see someone just to make sure we're not missing anything. If you're 35 and older, we kind of hold you to the 6 month standard and say, look, time is, age is the elephant in the room. Time is not on your side. We need to have a sense of urgency. So let's maybe get plugged in and make sure we're not missing something sooner rather than later. If someone has irregular periods, or there's a known male factor, or any other complication that could be associated with infertility, then it's reasonable to talk to your OBGYN about what, if any, workup you should do sooner rather than later, if there is something in the history, especially if it's irregular periods. Irregular periods is usually an obvious one that patients will know about, so that will prompt them to talk to their OBGYN. When we talk about the workup for infertility, I always like to use this visual and show patients this visual, because you're really thinking about the components of reproduction. And this isn't to insult anyone's intelligence, but you obviously need an egg that comes from the ovary. So you need an egg, you need sperm, and then you need open fallopian tubes. So these tubes have to be open because fertilization occurs in the tube, and then the fertilized egg transits down the tube into the uterus, and then it implants. The brain and the pituitary are controlling the communication with the ovary, and we'll talk a little bit about why that's relevant. So keep this picture in mind because I will be using it as we talk about the infertility workup. So let's first start with the ovaries. So 40% of couples who walk in the door of a fertility clinic, their problem is with the ovaries. Okay? So in order to understand the role that the ovaries have in reproduction, let's briefly review the menstrual cycle. So in the menstrual cycle, your brain sends a signal to the pituitary, which then sends a signal to the ovaries in the form of a hormone called FSH. FSH will recruit a cohort of follicles here in the ovary, and ultimately one follicle will dominate and be released. Before we get to that, let's talk about this cohort of follicles. Women are born with a fixed number of eggs, and that number declines as the age of the woman increases. It also declines more rapidly based on, if the woman is a cigarette smoker, if she's had surgery on her ovaries and had part of the ovary removed, if she's been exposed to chemotherapy. Those are 3 big risk factors that could greatly diminish the size of the cohort of follicles. Okay? So at the beginning of each cycle, there is a cohort that is available for recruitment. And for some people, that cohort is a large cohort, and for others, it's smaller. Okay? That's an important point to remember, because we're going to come back to how do you measure how do you measure the size of one's cohort of and tell whether it's large or small. But going back again, reviewing, remember at the beginning of a menstrual cycle, this hormone FSH will recruit this cohort of follicles. Ultimately, these follicles will start to grow and start to make estrogen, which I'll abbreviate as E2. That estrogen will then feed back to the brain and then tell the brain, hey, I got enough FSH. You don't need to send that signal anymore. I've got this large dominant follicle coming up. Estrogen will start to go up even more. And then that positive feedback will then prompt an LH surge. 36 to 48 hours after the LH surges, the egg is released and ovulation occurs. 36 to 48 hours. Okay? The structure that's left over from, and I'll draw it on this other side, the structure that's left over from where you ovulate becomes the corpus luteum, or the CL, and that starts to make a lot of progesterone. LH helps support the growth of that corpus luteum. The egg is released, okay, and it's either fertilized or it's not, and it's transiting into the uterine cavity. If it's not fertilized and or does not implant, this corpus luteum, which is making progesterone, will stop functioning. In order for this structure to continue to function, it needs HCG, and that HCG usually comes from an implanted from an implanted embryo. If that does not happen, then this corpus luteum will stop making progesterone after about 10 to 14 days. And as a result, the progesterone level will decrease, and the withdrawal of the progesterone will cause menstruation, and then the whole thing starts over again. Okay? So, with that in mind, if someone is, how do you know whether this system is working properly? Because one of the biggest problems that couples have walking in the door, again, 40% of the couples, this system does not work properly in those patients. So how do you identify whether it's actually working or not? Well, the simple thing is by taking a history. So someone who has regular, predictable menses every 28 to 30 days, they are ovulating. They do not have an ovulation dysfunction. Someone who is skipping periods, having cycles every 35 to 40 days or more in interval, someone who's having short cycles that are less than every 24 days, someone who's bleeding in between periods may have, these are the types of people that may have an ovulation dysfunction. So if they give you that history, they are probably not ovulating or have some underlying ovulation dysfunction. Now, it's important to remember that this part of the cycle is the follicular phase. and it's variable in its length. And again, remember, this is stuff we talked about in the menstrual cycle lecture. This part of the cycle is the luteal phase, and it is fixed. It's usually about 12 to 14 days, okay? So a patient who has long cycles and has periods every 35 days, they are probably having, their follicular phase is longer than someone who has 28-day cycles, okay? So let me say that again. Someone who has a 35-day cycle probably has a longer follicular phase and is probably ovulating cycle day 21, as opposed to someone who has a 28-day cycle who is probably ovulating on cycle day 14. Okay? So again, it's important to understand how this works because you're going to do some tests to confirm whether someone ovulates. So it's very important that you understand what the patient's cycle intervals are. People will also talk about, the patient might come in and say, hey, I did a basal body temperature chart, or I used an ovulation prediction kit. There are also lots of apps in the app stores that venture capitalists are trying to sell to people to have more conversations about their fertility. They're great tools, but they're just glorified basal body temperature charts. Ovulation prediction kits are kits that measure the urinary LH levels. They peak pretty much within 36 to 48 hours before someone ovulates. The LH level will surge. So one might start using an ovulation prediction kit at about cycle day 10 of a menstrual cycle, and when the kit turns positive, that means that the patient is probably going to ovulate in the coming 48 hours. So they would want to have intercourse to have sperm exposure or insemination to maximize the chances that sperm and egg will meet. The basal body temperature charts are based on the foundation that progesterone, an elevation in progesterone causes the basal body temperature to rise 1 degree. Again, we talked about this stuff in the menstrual cycle lecture. A progesterone level, a basal body temperature spike that occurs, on cycle day 17 of a cycle. It's important to remember that that means that the patient probably ovulated a couple days before that spike. So you can't use that prospectively. You can't use a basal body temperature chart prospectively. You have to use it retrospectively. Checking a progesterone level on cycle day 21 is another way to confirm that someone is ovulating. You have to be cognizant of what their cycle intervals are. So for example, if someone tells you I have cycles every 40 days, they probably have some underlying ovulation dysfunction, but they might tell you, hey, I have cycles every 40 days. My OBGYN keeps checking progesterone levels on cycle day 21, and they're always less than 2. So an ovulatory progesterone level would be greater than 3. So if you keep registering a progesterone level that's less than 2 on cycle day 21 in someone who has 40-day cycles, you're probably testing too early, because someone who has 40-day cycles is probably ovulating around cycle day 26. So their progesterone level is not going to be elevated before cycle day 26. So that's, again, another point why it's important to understand. That's why cycle interval is so important. So one final thing I wanted to say about PCOS. PCOS is polycystic ovarian syndrome. It is the most common type of ovulation dysfunction. PCOS is a subject in and of itself. I think it's just important to say that patients with PCOS have different phenotypes. But what I want to impress upon you is the definition of PCOS requires 2 out of 3 of the following: irregular periods. So if they're greater than 35 days or shorter than 24 days, elevated signs of male hormone. So basically hyperandrogenism. So if they have clinical signs of hyperandrogenism, lots of facial acne, acne on their back, chest, if they have excess body hair on their upper lip, chin, on their nipples, back, and chest, those are clinical signs of hyperandrogenism. You can also check serum markers for hyperandrogenism, like checking a total testosterone level. Also do an ultrasound to look and see if they have PCO appearing ovaries. So if they have large volume ovaries greater than 10 cubic centimeters, 10 cubic centimeters, that would be a PCO appearing ovary. So you need 2 out of the 3 of these in order to meet the definition of PCOS. But recognize that someone who has irregular periods and PCO appearing ovaries on ultrasound may be different than someone who has excess body hair and PCO appearing ovaries. So this phenotype is very challenging. This is highly variable. It's just important to remember that PCOS is a type of ovulation dysfunction and is generally approached similarly in patients who are trying to conceive as far as treatment goes. So let's stick with the ovary and talk a little bit more about age as it relates to the ovary, and then let's talk about actually what tests you should order. Okay, so I alluded to it earlier, but the ovary, remember, women are born with a fixed number of follicles, and you want to know perhaps how many follicles someone has available. So there are tests that you can do. So you can check markers of ovarian reserve. So ovarian reserve screens. Okay, examples of this are an AMH level. So AMH is a glycoprotein secreted by the granulosa cells. This level is a good reflection of how large or small the cohort is that is available for recruitment each month. The higher the AMH level, the more follicles you have available. The lower the AMH level, the fewer follicles you have available. Another test you can do is what's called an antral follicle count. This is an ultrasonographic representation of how large or small this cohort is. So antral follicle count and AFC tend to be concordant. Okay, so this is a blood test. This is a vaginal ultrasound in which we count the number of follicles. So again, antral follicle count is a vaginal ultrasound probe in which we count the number of follicles in the ovary. The higher this number, the more follicles you have available, the more follicles you have available for recruitment, the more responsive the ovary is to fertility treatment. FSH and estradiol. This is another ovarian reserve screen that tells me how efficient the brain is communicating with the ovary. So as the age of the woman increases, the efficiency at which FSH works to recruit follicles declines. So the brain, put another way, the brain has to work harder as the age of the woman increases to recruit follicles. So all of these tests are screening tools, okay? They are not diagnostic of who can and cannot get pregnant, but they're tools that we use to help assess quantity. Specifically, these 2 tests tell me about quantity of follicles. None of these tests tell me about quality. Age is still the best predictor of quality. But these tests I typically order on every patient who comes in for a infertility workup. There is recent data that shows that it's probably not a good idea to use AMH as a screening tool of one's fertility potential. So I have no infertility. I'm a 28-year-old female. Let me check my AMH level and see what it means as it relates to my ability to conceive. That is probably not a good use of the test, because the population in which this test probably has its best predictive value is in an infertile population that is probably going to pursue fertility treatment, specifically IVF. Nonetheless, we order these tests to help counsel patients and to set expectations about their treatment planning moving forward. Moving on to just general testing that we would do. So patients who walk in the door, I like to get these two tests, and typically this one on everyone who walks in the door who's over the age of 30, and pretty much everyone else who is under the age of 30 as well. The testing that I would also do as it relates to the ovary is I like to check a TSH level. This has some value in just making sure, if someone has some irregular periods, obviously checking a TSH is important. If they have irregular periods, checking a prolactin level is important because they might have a prolactin secreting adenoma that can disrupt their menstrual cycles. I like to do an ultrasound, and as I mentioned, that's where we would measure the antral follicle count. It also helps me look at the ovarian anatomy and obviously the rest of the pelvic anatomy, including the uterus and the tubes. If someone has stigmata of PCOS, specifically hyperandrogenism, then I would also check a 17-OHP just to make sure they do not have non-classical CAH, looking again for a 21-hydroxylase deficiency. And I would also check a serum testosterone, so a total testosterone level. Now again, these here, 17-OHP, total testosterone, prolactin, are for people who have irregular periods, and the 17-OHP, total testosterone, signs of hirsutism, hyperandrogenism, okay? If the patient is obese and meets the criteria for PCOS, I will also check a hemoglobin A1C or a 2-hour GTT. Okay, both of these things are valuable. Hemoglobin A1C is just easier to do because it's one blood draw. A 2-hour GTT is just a little bit more inconvenient for the patient. It requires one blood stick and then another one 2 hours later after drinking, a high glucose content soda. So this is generally the workup I do for the ovary when a patient with infertility walks in the door. Let's move on now to the sperm, okay? So let's move on to sperm and male factor. So if the patient's partner is male, obviously we want to look at the semen parameters and make sure the sperm is okay. It's important to note that 50% of couples who walk into the door will have a male factor. 50% of people who walk in the door will have a male factor. That's very important to remember. So you can't just brush aside, well, it's most likely the female. No, it's actually just as likely to be the male. So it's important to do a semen analysis. So a semen analysis is very simple. So that is the first screening test that is done on any partner. So the semen analysis is pretty straightforward. The patient has to basically provide a ejaculatory sample after abstaining from ejaculation for 2 to 5 days. So what we tell patients is to abstain from ejaculation for 2 to 5 days. And then they present to our office and they give a semen sample. We then look at that semen sample and look at specific parameters: volume, concentration, motility, which is broken down into total and progressive. And then we look at morphology. Okay, so these are very important parameters. If the volume of the ejaculate is less than 1.5 mils, then we might be concerned about an obstructive problem somewhere. If the concentration is less than 15 million, that is high risk for infertility. Okay, so let me stop and make a point. These cut points, these reference ranges, are based on a cohort of about 2,000 men who were followed, who contributed to a pregnancy over the course of a year. So they basically followed all these 2,000 men, looked and saw who had pregnancies, who didn't, did semen analyses on all of them, and then came up with percentiles from the 2.5 percentile to the 97.5 percentile, and basically broke out all these parameters into those centiles. So this reference range on a semen analysis is the less than 5th percentile. So put another way, if you are under 15 million, you're in the less than 5% of men who contributed. So less than 5% of men who had a pregnancy in the prior year had a concentration less than 15 million, or a volume less than 1.5. Moving on, motility, we like it to be about 40%. Motility can be broken up into total and progressive. So total motility, we like to be about 40%. Progressive motility, we like to be at about 32%. So you can have sperm that's just moving in circles, or you can have sperm that's moving forward. This is the progressive fraction. This would be counted in a total fraction. So progressive motility is important because you want to make sure that sperm can move through the female genital tract. Morphology. So 4% morphology is the 5th percentile. So we like to see at least 4% of the sperm normally shaped. Obviously, sperm can have, 2 heads, 2 tails, half a head, no head. Those sperm cannot fertilize an egg. So as long as there's at least 4% normal shaped sperm in the millions of sperm in the ejaculate, that's good enough. So we usually, if one semen analysis has an abnormal value, I usually like to repeat a second one. So you usually like to do 2 semen analyses if one is abnormal before drawing conclusions about whether or not there's a male factor, and then you proceed with treatment accordingly. So I want to talk about risk factors. So when you're talking to guys, it's important to screen them for risk factors for abnormal semen parameters. So those risk factors would be, testosterone use is a big one. History of infection like mumps, or any other genital tract infection like chlamydia. Marijuana, chronic narcotic use. These things can disrupt how the brain communicates with the testicle and disrupt spermatogenesis. Cigarette smoke and alcohol can affect spermatogenesis as well, so it's important to screen for excess use. Obviously, they are associated. So if you look at the data, these smoking and alcohol are associated with lower semen parameters, but there is no data that shows that actually makes the leap to they cause infertility. So it's ultimately a good idea to curtail the use of marijuana, cigarettes, alcohol while you're trying to conceive. I also like to ask guys about surgery. So any kind of pelvic surgery, hernia surgery, those things can disrupt the blood supply to the testicle, the nerve supply to the testicle, especially if the surgery is a radical one in the pelvis. So it's important to ask about a history of undescended testicles. Some guys may not provide that information up front. If someone had an undescended testicle and then they needed surgery as an infant to correct that, that surgery could have been harmful to that testicle's just general ability to function. Chemotherapy, any cancer treatments, those would obviously be a high risk for compromising spermatogenesis. All right, so let's move on to the tubes. There are risk factors for tubal disease. So any risk factors are like chlamydia, surgery, endometriosis. So any kind of inflammation in the pelvis is basically going to disrupt the delicate structure of the fimbriated end of the tube and its ability to move and pick up the ovulated oocyte. It is possible for this tube to pick up an oocyte from this ovary and vice versa, but it probably happens 30% of the time. Endometriosis is an inflammatory state in the pelvis. Someone who had a ruptured appendix, someone who's had any kind of bowel surgery, pelvic surgery that's open, is likely at an increased risk of having some scar tissue that could distort the tubal anatomy. Chlamydia is obviously the big offender. An ascending genital tract infection can disrupt the tubal anatomy as well. So it's important to screen patients for these kind of risk factors, because if they do have them, that kind of makes it an easier sale to do an HSG or a tubal evaluation. So an HSG is the test that we use to evaluate the tubes. So the test is called a hysterosalpingogram. Okay, so it's a test that basically helps us understand whether your tubes are open or not. So what happens in this test is the patient goes into the radiology suite and basically has a pelvic exam under the X-ray machine. The physician puts a catheter into the uterine cavity, into the cervix, and then pushes dye through the uterine cavity. Now remember, the uterine cavity is a potential space. So when you put dye in it, it expands, and that expansion causes a lot of cramping and pain. And while that's happening, the physician the radiology technician is taking pictures showing two things. One, the uterine cavity and its contour. Is it normal or not? Are there filling defects? Is there some polyp here? Is there a septum? Okay, those things would show up on an HSG. The other thing that's the HSG is really known for, and really its most sensitive piece, is it tells us whether the tubes are open or not. So it tells us about fill and spill. So you want to know whether the tube fills and then whether it spills. This is the proximal part of the tube. This is the distal part of the tube. Okay. On the HSG, sometimes dye does not fill. It just kind of it stops here, so you don't see the tube fill. That is not sensitive for not very sensitive for tubal disease. You could have spasm of the tubal ostia that could prevent the dye from going into the tube. So sometimes you have to repeat this study in that case to confirm that they truly are obstructed or not. Patients who have fill but no spill and are distally occluded usually have some significant tubal disease, and the test is very sensitive at detecting distal disease. The HSG is the best screening tool that we have for tubal disease. The gold standard, so if there's something on the HSG that looks abnormal, like if you're not sure whether there's distal spill or not, the gold standard would be to do laparoscopy and actually go in laparoscopically and just look at the pelvis directly and push dye directly and visualize. You can look at the tubal anatomy directly and then visualize whether there's actually spill or not and whether there's adhesions around the tube. So laparoscopy would be the gold standard, but it's invasive. It's largely not necessary for most patients, so that's why we start with the hysterosalpingogram. So at this point, we've kind of reviewed the workup for the ovaries, the sperm, and the tubes. Now, again, we talked about 40% of couples having a ovary problem. 50% of couples could have a male problem. Depending on the WHO did a study and showed that 30% of couples who can walk into a fertility clinic can have up to 30% of problems can have a tubal problem. Also recognize that a lot of patients may have multiple issues that could be disrupting their reproductive efficiency. There is a phenomenon called unexplained infertility. And this is frustrating because it's kind of a general category that's defined by normal periods, normal sperm, and normal tubes. And this is 30% of couples will fit into this category where they have unexplained infertility. A lot of folks with unexplained infertility, if you look, they might have a low ovarian reserve or diminished ovarian reserve. Their AMH level may be on the lower side. So we treat these people empirically, much like we treat a lot of the other patients. It's important to remember that fertility treatment in general is oftentimes an empiric treatment. And we'll get to that in a different episode. This largely ends the workup. There's one other point I'll make on this slide about endometriosis. So endometriosis, which deserves its own segment, but just briefly, endometriosis is a clinical phenomenon in which the pelvis is inflamed. Endometriosis is where glands and tissue from the endometrial lining exit through retrograde menstruation is the most common theory, and they implant into the pelvis. And those sites in the pelvis cause aberrant inflammation. That inflammation can then distort tubal anatomy. It can disrupt sperm-egg interaction. It can disrupt implantation. And there may be some evidence that it can disrupt egg quality. There are different stages of endometriosis. There are minimal disease, and then there's severe disease. So there's a lot of endometriosis is not well understood, but as it relates to the workup, you usually just try to elicit from the history some key points that might increase the risk that the patient has endometriosis, and then you kind of make decisions about whether it makes sense to go looking for endometriosis in the patient whose chief complaint is fertility and not necessarily pain control. This is a complex topic, so I'm kind of glossing over it, and we'll save it for another time. But in general, someone who has painful periods, pain with intercourse, that got better when they were started on birth control pills, and then since they've been trying to conceive and stop the birth control pills, the pain has gotten worse. That could be someone who's at risk for having endometriosis. And discussion about whether it makes sense to go looking for endometriosis, because the best way to diagnose, or the gold standard tool to diagnose, is with laparoscopy. So 25 years ago, a lot of folks part of the infertility workup, especially people with unexplained infertility, was to go in and do laparoscopy. But because technology has gotten so much better, specifically fertility treatment options like IVF have gotten so much better, we typically don't do this anymore unless the patient has concerns about pain control, and the chief complaint is actually pain control over fertility at that moment. So we'll wrap up here. That ends the infertility workup talk. I hope you've enjoyed this. I hope this was helpful. Please let me know if you have any comments. Thanks a lot, and enjoy the rest of the day.